My name's Phil Rutherford, and I'm here today in the capacity. I'm CEO of Black Faces, Black Voices. I have a bit of a dual role. I'm also in my day job the strategy lead for substance use at the National Council for Mental Wellbeing. So I wear a lot of hats. But what we're here to talk about today is the elephant in the room: stigma and the deadly effects of the war on drugs. And as I was thinking about this presentation and kind of thinking through what I wanted to talk about, whenever, stigma is a big word. We talk about stigma, at least in the substance use disorder space or in the behavioral health space. We talk a lot about stigma and the different components of it and how to treat it, fight it, break it, so on and so forth. But I thought for this talk, it was really important that we kind of address how we got here. And it is in some ways the elephant in the room, because there's some components of stigma specifically in Black communities that I'd like to unpack. Before I get to that, I don't have any disclosures to give. This says that the opinions expressed herein are views of me and not necessarily UMKC or anyone else. And I appreciate that, and believe me, the folks at UMKC and elsewhere, once I'm done, they will really appreciate that these aren't their views; they're mine only. I also don't have any conflicts. I aspire one day to being the kind of man that has conflicts of interest to disclose, but I don't have any of those today. Also, if you're here for a very serious and really very targeted presentation, I don't know if you'll get that out of me. I do crack a joke now and again. So here we go. Yep, no financial relationships, all that. You already talked about the credits. Okay, here we go. What I'd like for you to be able to do by the time you complete this is to identify the harmful impacts of stigma and the war on drugs in the Black community, hopefully to differentiate between internal and external stigma, identify health equity disparities in prescribing, and describe various methods of stigma intervention. And we'll see if we get there. The marketing folks say I have to do this. Black Faces, Black Voices is a national collective of Black SUD recovery professionals whose purpose is to bring visibility to the Black recovery movement and help promote culturally responsive addiction services that meet the needs of Black people. BFBV joins the skill sets and broad reach of its membership of physicians, psychologists, researchers, and peer recovery leaders to provide depth and dimension to delivering health equity to the Black community. And I think at last count, we were talking about this the other day. I think we're about 100 organizations. We're in 39, we're representing 39 states, and we're a collective. So we're not an organization in the traditional sense of the word, where just about everyone that is connected with Black Faces, Black Voices has some other sort of work, but we are grouped together because we are concerned about resources going into the Black community, and specifically around wellness and substance use disorder recovery. So that's what we do. I want to get started with a quote. And this particular quote, I'm going to read it for dramatic effect, and then we'll talk a little bit about what it means. It says here, the Nixon campaign in 1968 and the Nixon White House after that had two enemies: the anti-war left and Black people. You understand what I'm saying? We knew we couldn't make it illegal to be either against the war or Black. But by getting the public to associate the hippies with marijuana and Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. Some of you may know who John Ehrlichman was, but that's a quote from John Ehrlichman, who's an assistant to President Nixon in the Domestic Affairs Department. Certainly one of main contributors to Nixon's war on drugs. And here's we're starting here, but to be clear, racialized drug policy in America did not start in 1970. There were challenges with drug policy in the late 1800s on the West Coast with Asian Americans and imports of opium. So it's not this wasn't necessarily a new thing, but this started a particularly virulent chapter in American history of racialized drug policy. So, um, what happened then? Well, it began the war on drugs. So in 1971, President Nixon issued the Controlled Substances Act. The DEA was born in 1973. In 1984, the first national strategy for prevention of drug abuse and drug trafficking showed up. There was sentencing reform, which introduced mandatory sentencing for drug offenses. And this is really a period of criminalizing drug use. And one of the things I was having a conversation with someone recently about drug use in general, and it came up that I think 40,000 years ago, they found remains from a cave in France, and it was a pipe. It was people. They found skeletal remains, but there were pipes there for people who were smoking tobacco. So it is evidence that people have been using drugs for 40,000 years. So they knew that there was tobacco in the pipe, so that people were using nicotine 40,000 years ago. So the business of humans using drugs is not a new event. Didn't just show up in 1984 when this policy was introduced. But probably one of the most damaging things to the Black community was this 100-to-1 mandatory minimum that happened with the Anti-Drug Abuse Act in 1986. And what that meant, if you're not, and again, I'm not sure exactly who's on the call, so I'm just gonna, if I'm boring you with this information, I don't know, check your email. Um, but the 100-to-1 sentencing thing said that if you have cocaine in its powder form, you get 1 year. If you have cocaine in crack form, which is simply cocaine put in water and boiled with baking soda, you get 100 years. And it wasn't exactly that way, but it was 100-to-1 um, in terms of the way that they counted the substance. And the reason that is so ridiculous is that if we were to extend that to a different substance, and let's say we're talking prohibition time, that would mean that if you had whiskey, you would get X penalty. But if you had vodka, you would get 100X penalty. That seems silly, right? They're both ethanol. It seems outrageous that one would be highly penalized. Um, the challenge with that is that really started this move toward mass incarceration. Um, and I suppose we wouldn't be having this particular conversation. We probably have other conversations about disparities, but we wouldn't be having this conversation about disparities if not for this fact that 80% of the people in federal prison under this sentencing guideline and 60% of the people in state prison for drug offenses are Black or Latino. And that is really who those sentences, that's really who that mandatory minimum and 100-to-1 penalty. And by the way, just to be clear, the 100-to-1 penalty was not about time, it was about quantity. But the 100-to-1 sentencing, that really impacted the Black community. And again, the reason we're talking about this is we're sort of unpacking how stigma is affecting the Black community today. Some of the roots of that absolutely exist in the crack epidemic. Um, and the other thing is, even calling it the crack epidemic, we call it that now. That's not what it was called during the time. It wasn't. It wasn't. That's not. We didn't talk about things like epidemic. Sounds like something that's happening to people. We weren't really as concerned and I lived through that time frame. We weren't really as concerned with the individual substance users at that time. We were concerned about protecting society from them as opposed to helping them. And this period of time really gave rise to punishing drug users. And so we did that. And we did it disproportionately, much like a lot of criminal legal policy in America, this was no different. So, we talk a lot about social determinants of health. If you think about what disproportionately investigating, arresting, adjudicating, and sentencing a group of people, specifically along racial lines, let's look at what it affects. Well, if you're a felon in many states, you can't vote. That's been cleaned up a little bit since the time of mass incarceration, but largely still true. Um, in challenges with employment, um, there are plenty of families that were separated as a result of this. There was a law passed that you couldn't get student financial aid. There's an entire generation of young Black people that missed out on student loans because of the criminalization of some of these substances. Um, and this is really when we talk about stigma. So there's a stigma of being a substance user, and then there's also the stigma of there are plenty of people in Black communities that watched all this go on and thought, oh my God, I got to make sure my kids are safe. I got to make sure that my family, everyone is safe. And I don't want any of that foolishness going on in my house. That has an impact on the way that people thought and felt about people who use drugs. Like today, there's a drug users union. Um, I promise you, in the 80s, in Black communities, the idea of a drug users union, like I mean, it's laughable, right? Like there was no space for that because the community was under attack, largely from a hostile external force. And if you want to add some dimension to that, we also know that at that same time, there's a mythology that the CIA was importing drugs. That's not what was happening, but the CIA was absolutely turning a blind eye to the importation of drugs at that time. We know that from federal from sworn testimony in federal court that the CIA was allowing the importation of drugs to fund a war in El Salvador. So at the same time, one section of government is allowing the substance in, another section of government is arresting and incarcerating a group of people along racial lines. So that in of itself had sort of a double impact on the community and a double impact on the way that not only people, not just the way people perceived law enforcement, but the way Black communities perceived itself and the way it perceived each other. So there are all sorts of collateral consequences associated with that impact the way Black communities observe drug use, drug treatment, getting well, et cetera. And by the way, I know that some of this content might be making someone on the call uncomfortable. I'm okay with that. So, where are we today? Well, 50 years later, spent $1 trillion. Um, I'm sure that there's some good was done by that, but I would posit that we are not necessarily closer to solving. We're certainly not closer to solving addiction or substance use disorder today than we were 50 years ago. And the havoc and damage and families disrupted and lives lost as a result are are, are large. If we look at incarceration of people with drug offenses, um, we have also seen a dramatic increase there. And I know I'm hitting you with a lot of stats, but it's really, I think sometimes when we talk about stigma, we act like stigma is some sort of distant kind of just sort of almost like the boogeyman, like it's a thing out there. Stigma about substance use in the Black community is supported by facts, right? It's supported by by hostile drug policies specifically to our communities, and that's what I'm trying to build a basis of here. Since since 2000, this is probably a familiar chart to many of you. We are in the third wave of an opioid crisis. First wave would be the prescription medication, prescription opioids that were overprescribed, caused quite a bit of damage. Second wave would be heroin, although as a result of a couple of things. One is the United States military leaving Afghanistan, subsequent takeover by the Taliban, and the Taliban essentially burning quite a bit of the poppy fields and cracking down on poppy producers. Heroin is largely gone away. Um, what I do hear from people who use drugs is that heroin has become sort of a boutique drug. It's not really it's kind of, I don't know if artisanal is the right phrase, but it's just not really present. Everything is what we're in the third wave of the opioid crisis, and that is the rise of fentanyl. Um, and today, 76% of all the overdose deaths are there there are opioids present, and a majority of that is fentanyl. If you look at overdose death rates year by year, and this is only through 2022. The 23 provisional numbers are out, and again, depending on how close you are to this kind of work, there has been a 3.5% reduction in overdose deaths. Unfortunately, the estimates are, and again, there's provisional numbers because it takes a minute for all of the, you think of, what is it? There are 3,000 counties in America, and that's typically how these numbers are compiled. It takes a minute for all of that data to get in, but the early estimates is that there's a 3.5 reduction in overall deaths, but a 7% increase in Black communities. So, what that means to me is that the things that are working in other communities are not working in Black communities. And at Black Faces, Black Voices, we believe that to be a function of a couple of things. One of them is stigma. And if you look at these numbers, this, like I said, this is just through 2022, but you can see in Black and in indigenous communities that the numbers are just they're not just bad, they're outrageous. Um, and we it is really important that we understand that there's no these communities, while there may be different cultural things, but naloxone removes opioids from everyone's system. So, if we get enough naloxone into enough noses or arms or wherever we put it, the thighs, if we get enough of that into people, we can reduce overdose deaths in all communities, not just certain ones. Here's some stuff on funding. I won't go for this audience. This may or may not be particularly valuable to you, but we're spending money. There's money being spent on drug control stuff. I am not a supply side type. There are some that believe that there's some answer to this in the way of supply. I am not one of those. I did a co-presentation with a gentleman named Ben Westoff, who actually went to China and interviewed a number of the people that are producing precursors. And just so if you don't know what that is, what the way that the majority of the way fentanyl is being produced right now is that people are buying precursor chemicals, which are chemicals that can be used to produce fentanyl via a chemical reaction. They're buying them from China, and they're coming mostly to Mexico, and fentanyl's being produced in Mexico and smuggled in. If you got any border security enthusiasts, stop it, because 93% of the containers that come across the border are not inspected. So unless we're suddenly going to turn all of our national defense budget into container inspection at the southern border, border security is not going to fix that. But the reason that I'm not a supply side guy, is that the system in China. So China has a very, very tough criminal legal system. Something like 90, I want to say it's like 98% of the people that are charged in the criminal legal system go to prison, right? So it's not like there's no, you don't get off. If you're arrested in China, you're going to jail. So people are very afraid of breaking the law. And the Chinese government works directly with the DEA to stop the production of precursor chemicals. The problem is something called novel analogs. And I don't want to get too nerdy with this, but if you think about the structure of any chemical, it's got a carbon here, a hydrogen there, an oxygen there, maybe a sulfur here, whatever it is. Um, the Chinese government can say, okay, this chemical of this molecular structure is illegal, and many of the organizations that this gentleman Ben Westhoff talked to are like, okay, it's illegal. We're going to stop making it. We don't want to go to jail. But if you change this one molecule, it's no longer illegal. So they can make a novel analog that can be converted to a different, a slightly different type of fentanyl. They can make it legally and ship it over here or ship it to Mexico, and still produce fentanyl. So I don't think that there's any I don't know that there's a good solution for that. I believe that the solution for us will exist on the demand side and will exist on helping people to find some measure of wellness. And I'm not an abstinence only type. So whatever wherever that wellness exists is where I think we want to support people. So just want to touch briefly. And I know I'm supposed to be done by 40 minutes, and I think I will be. Um, why isn't this response working for Black Americans? And we talked about the external stigma um, of just substance use disorder and external stigma for the Black community. Um, there's not enough time in this thing to explain why there's external stigma on the Black community, but you take my word for it, there is some. We know that there's a correlation between mental health and overdose. We know that in general, people in the Black community have less access to mental health or substance use treatment due to economic issues, insurance issues, healthcare deserts. Don't get me started on deserts, healthcare deserts, pharmacy deserts, naloxone deserts, food deserts, all sorts of deserts seem to crop up in poor communities, not just about Black, but mostly about poor. All of those things are conspiring to make it difficult to get treatment out to the Black community. And the thing is, like I said about naloxone, we know that naloxone works. And I live in Minnesota, and this isn't this we I think we got a handle on this now, but maybe a year and a half ago, maybe a little bit longer, we were looking at heat maps of where naloxone was present, and we looked at Minneapolis, and all over Minneapolis, there's just naloxone everywhere. And there was just one spot that seemed to be missing naloxone. Um, I know you guys are probably blocked where you can't talk, but I would if anyone wanted to guess what that particular spot that didn't have a lot of naloxone in it, what the population of that spot was, it was the largest Black neighborhood in Minneapolis. And I don't think there was someone sitting there saying, okay, how do we stop naloxone from getting here? I don't think that's how it works. But I think the way that it works is there wasn't a lot of training going on. There weren't enough trusted messengers in the community sharing information about naloxone. The community itself was resistant to talk about drug use and um, maybe a lifestyle that didn't include complete abstinence. All of those reasons conspired there. But nonetheless, when I look at the map, there's this big open spot. And I think that is not unique. That's not a Minnesota thing. That's not unique to Minnesota. I think that has existed and still probably to an extent exists around the country. Um, so, and this chart is just some data that sort of explains that. If you look at training, possession, daily access, you'll see the numbers across the bottom they're lower than every other community. And the thing is, you don't even have to believe any of the others stuff about disparities. Actually, a lot of it's data. So if you don't believe data, again, I can't really help with that. But these numbers, the lower you would, a logical assumption would be that the lower these numbers, the higher the overdose death rates are, and that is true. So there's not this is not. I'm not even looking for um, deductive reasoning. If you have less naloxone present, less naloxone trained, it makes sense that you would have more death, and that's what we got. Let's talk about some recommendations for both preventative and holistic health. Um, Thing number one: funding harm reduction research and policy. Um, and when I say research, I one of the things that at Black Faces, Black Voices is we not only are we interested in research on Black communities, but we think it's really important that that research be carried out by Black folks. And I think that it's really important. We've done some research on our own with partnering with a couple of other agencies, but we one of the pieces of feedback that we've gotten from people that we've done the research on is, hey, we've never seen a Black researcher doing this work, right? Which is a really weird thing to hear from people in community, but nonetheless, um, we believe that there is efficacy to getting good community level interventions going by doing work from people by people that are from the community. Um, we like the idea of having peers to prevent solitary drug use. Um, I've said all I can say on tough on crime legislation, and the thing is, I don't. I think that we do have to have laws, and there have to be rules, and people that break rules, that's fine. But in every statistic that exists, uh, Black folk and Latinx folk are investigated, arrested, adjudicated, and sentenced at a much higher rate. So when we talk about tough on crime, are we really talking about tough on crime, or are we talking about tough on those communities? So I'm not going to do the decriminalized drug possession part. I believe in it because I think that in addition to not, like I said, not disproportionately impacting communities of color, I think it also could make for a safer drug supply. But there are plenty of opponents to this. This is definitely more of a your market may vary. If you're on here and you're from Oregon, don't be mad at me, but this can work. Portugal being an example. Um, and again, pretty much anything that is criminal justice related is seems to be bad for for the Black community. Equitable access to culturally informed harm reduction, treatment, and recovery options. These are all good things. Um, I'm also a fan of on the holistic side of prioritizing investment in communities impacted by discriminatory policies. And I know there's no quicker way than to get a room silent and ready to leave than to mention a word like reparations. But there was a lot of harm done specifically to Black communities in the 80s and 90s as a direct result of a flawed drug policy and a poor execution of of I don't even know what to call it, but poor execution of drug policy in those times. And I'm not necessarily talking about money to people, but I'm talking about money to communities. I'm talking about money to there are communities that have never recovered from what happened during the crack years. There are Black communities that have never been the same since then, and I think that it is of value to look at that. Um, and then just finally, I guess I'll leave you with this thought: the kind of the whole person, right? And the not just that. And housing first is an excellent model, but there is so much trauma that exists in Black communities around this particular thing, around the drug raids of the 80s and 90s, around uh, profiling, around seeing fathers, grandfathers, brothers, all of those people carted off. Um, there's work to be done there in a very holistic way, and I think that's feel like that's an important thing at least to consider, because after 50 years and $1 trillion, I don't know that we have moved the needle in that way.